Hello, everybody. Today we talk about post-ASH 2022-25. Today we focus on the CAR-T therapy in multiple myeloma on the several presentation by several doctors. The first one is Dr. Richard. She present dual CAR-T target CD19 and BCMA for relapse and refractory multiple myeloma, and the total efficiency, the OR is 96% and the CR rate is 78%. Interesting is for some patients, 5 patients who is BCMA CAR-T exposed, the OR is 100% and the CR rate is 80%. The median follow-up is 3.9 months. And the median time to first response is 28 days. So our department also developing a clinical trial to evaluation the dual CAR-T also target CD19 and BCMA. So we hope we can show our data recently. And the second one is presentation by Sandana. And in this presentation, the evaluation the safety and efficiency of cilta-cel in real-time world data, and they focus on the neurotoxicity, delayed neurotoxicity, and other side effect of the CAR-T cell. The Parkinsonism rate is 2.9%. There's 22 patients was developed Parkinson's disease. So this is severe delayed neurotoxicity post CAR-T therapy. And they also they also evaluation what kind of prediction for the risk of Parkinsonism, and they find that the ALC threshold is risk factor for Parkinsonism, and the ALC, if the ALC is increased more than 3,000 or 2,500 cells per microliter, the Parkinsonism risk will be increased dramatically. Compared with others, the ALC is less than 2,500 and 3,000 per microliter. So also for the CAR-T therapy, including whether in the CD19 targets, CAR-T therapy in large B-cell lymphoma and BCMA target CAR-T cell in the multiple myeloma, the bridge therapy is useful, necessary or not, is doubled. So we also did not recommendation the patients necessary to accept the bridging therapy before CAR-T therapy. But in this presentation, they found that the responsible to bridging therapy is a risk. Is a risk for Parkinsonism in the multivariable analysis. If the patients get a PR in the bridging therapy, there's a lower risk to developing Parkinsonism after CAR-T therapy. So this is a very interesting result to help us the evaluation whether this kind of patients could be develop a risk of Parkinsonism and no relapse mortality. So also that's bridging responsible, and the peak ALC. This is a two isolated identified risk factor for us to evaluation whether these patients have a risk to developing Parkinsonism and no relapse mortality after cilta-cel. So this is an interesting presentation. Another one is presented by presentation by Professor Hansen, Dr. Hansen, the evaluation whether this high risk myeloma could influence high risk could be influence the outcome of CAR T therapy. The evaluation many kinds of definition of high risk, especially for the IMWG high risk definition. Also, they focus on the more than one high risk factors, including the EQ and EP deletion, EQ amplification again, and 1P deletion and translation of IgH. They found that this also for these patients, if the patients get a CAR T therapy for the 12 months PFS, the high risk patients will have a shorter PFS compared with those patients without high risk patients. So this indications that although the patients could be receptive of CAR T therapy, but the high-risk patients also may have a shorter PFS compared with those patients without high-risk factors. They also detect the MRD status, the relationship between the high-risk factors and the MRD status. They find that more than in those patients with more than one high-risk factors, they have lower MRD negative response, and also this could be affect the PFS rate within 12 months. So also this if these patients have more than one high risk factors, this kind of patients will have shorter PFS, also shorter OS. Also the p-value is all lower than 5%. So they have the multivariable analysis for the PFS and for the relapse within 18 months. They found that high risk factors is independently associated with the PFS. Also, when adjusted for the ferritin, previous BCMA, and a COG PS over than 2 points. Also, for the patients relapse within 18 months, this kind of high risk function, IMWG high risk patients, also the independent factors for the relapse risk. So also while the MRD, the EMD is not the risk factor for those patients relapsed within 15 months. Also, in the Cox model analysis for the high risk factors associated with inferior PFS within 15 months, this shows function high risk and IMWG high risk are associated with relapse within 15 months, but not in the PFS over over 15 months. So this indications the high risk patients have more risk to relapse within 15 months compared with the patients without high risk factors. Also, the EMD PFS is similar in the both time period. I mean that's the EMD is also is isolated increase isolated factors to affect the response for CAR T therapy. So there's conclusion that high-risk patients also could be lower PFS and lower response but shorter survival after cilta-cel. Mainly, we think that after CAR T therapy, we need more consolidation therapy or combination with other strategies such as bispecific antibodies or immunomodulation drugs to improve the MRD negative rates in the high-risk patients and to maybe that could be helpful for the survival of this kind of high-risk patients after CAR T therapy. Also, Dr. Mian also provide some analysis of CAR T therapy to compare the FREEL cohort and the non-FREEL cohort. They showed that the PFS and the OS in the FREEL cohort is inferior in the FREEL cohort compared with the no-FREEL cohort. And this mainly is the prolonged cytopenia in the toxicity. The prolonged cytopenia is more prevalence in the FREEL cohort compared with the no-FREEL cohort, but the infection is just balanced. So this cytopenia, prolonged cytopenia, could be more be more compared could be more attractive in the FREEL cohort. And also in the multivariable analysis, they showed that the overall response rate and the CR rate is comparable comparable in the FREEL cohort and the no FREEL cohort. That means the CAR T therapy's efficiency is the same, is not affected by the fertility. But the PFS and OS, especially the all-grade icons, this all are just affected by the frailty. That means in the frail status it could be affected PFS and OS, also the all grade icons effect. So for this kind of patients who is frail, in the frail cohort, we should pay attention to the prolonged cytopenia and the all-grade icons side effect. If we can manage this kind of side effect, maybe could be improve the PFS and OS in this kind of frail patients. So this presentation highlights the support therapy in the frail patients who accept the CAR T therapy. This is a very interesting and very valuable result for us to manage this kind of patients accept CAR T therapy. That's all.